Good morning, everybody, and thank you for joining us for this session. I think we have a very interesting lineup of talks ahead of us. So I'd like to introduce our first speaker, which is Professor Brian Badgwell. He is a professor of surgery at the Division of Surgery at MD Anderson, and he has a special interest in gastric and gastroesophageal cancer, as well as advanced laparoscopic surgery and intraperitoneal chemotherapy. He has run several HIPEC trials and is currently ongoing trials in intraperitoneal chemotherapy, where he is the principal investigator. He also has a special interest in palliative surgery, for which he has a palliative surgery research program at MD Anderson. And today we'd like to invite him to share with us on his experience in laparoscopic HIPEC. Professor Badgwell.
My name's Brian Badgwell. I'm a surgeon from MD Anderson. I specialize in gastric cancer, and it's an absolute pleasure to be with you here today and to be able to lecture on HIPEC for gastric cancer. It's a passion of mine to treat the most common site for metastatic disease in gastric cancer. I have no disclosures. HIPEC is hyperthermic intraperitoneal perfusion with chemotherapy. When combined with cytoreduction and debulking, it is the standard of care for appendiceal tumors as well as mesothelioma. It's relatively controversial for colorectal cancer, especially with some of the recent randomized controlled trials out of Europe. But what you can see from this picture here is a very small appendiceal mucocele that, when it ruptures, can turn into a big problem with a large amount of gelatinous contents, otherwise called pseudomyxoma peritonei. And in that situation, the standard of care is to perform an aggressive debulking and then a perfusion. And so this is a basic perfusion setup here with a roller pump and a heater element. And you can see the inflow and outflow cannulas going to the patient. So my outline for today is I'm going to present on metastatic gastric cancer as an example. First, I'll outline the problem of peritoneal disease. Then I'll discuss HIPEC for metastatic gastric cancer and some of the literature that's out there. Then I'll talk about our trials of neoadjuvant laparoscopic HIPEC. We'll briefly touch on laparoscopic HIPEC for other disease sites, and also talk about other neoadjuvant approaches to peritoneal disease. So peritoneal metastases from gastric cancer are bad. I don't have to tell this audience that, with median survival rates of approximately a year or less. Current National Comprehensive Cancer Network guidelines, at least for the US, recommend systemic chemotherapy only or best supportive care. And I've shown a few patients here, and these are patients that had negative imaging for peritoneal disease, and then when you perform a laparoscopy, you can see relatively high volume peritoneal disease here on the left with carcinomatosis. This is a stomach with diffuse serosal invasion consistent with Leonidas plastica, and just relatively high volume peritoneal disease. Over here on the right, this is a patient that had also serosal invasion of the stomach, but no visible peritoneal disease. And it was only when performing peritoneal washings we were able to identify the peritoneal disease. But this is why we perform a diagnostic laparoscopy in really every patient at our center that presents with a T2 or thicker lesion. And first of all, you can find visible carcinomatosis, as shown in the blue, in approximately 20% of the patients. And then we're performing peritoneal washings. We can find positive cytology in approximately another 10%. And then the findings outlined in green are such things as liver metastases or other findings that can influence the treatment plan. So overall, you're running approximately a 30% to 36% chance of finding some peritoneal disease when you perform a laparoscopy. So it's critically important to perform this in all newly diagnosed patients. Even in patients that undergo a laparoscopy, are treated with extensive preoperative therapy and a potentially curative surgery, the peritoneum is still a problem. And we showed this when we looked at our most common sites of recurrence, and the peritoneum was identified as being a site of recurrence in approximately half of the patients. And so even after extended preoperative therapy, the peritoneum is a problem. Now, there are some randomized controlled trials that support HIPEC in gastric cancer. This is the only randomized controlled trial to date. It's out of China. It's a relatively small study for China, 34 patients in each arm. And what they did is they compared cytoreductive surgery alone to cytoreductive surgery in HIPEC. And this was in patients with established carcinomatosis. The investigators used flat doses of mitomycin and cisplatin, although we often use body surface area adjusted doses for HIPEC. as this is the only randomized controlled trial and they used flat doses, we were left with this in some of our subsequent studies, which I'll show later. But what they found is a signal here that HIPEC works for carcinomatosis. And so as shown in the blue, those were the patients that underwent the HIPEC in addition to the cytoreductive surgery, compared to the cytoreductive surgery alone. Now, median survival rates weren't great. The overall survival rate was 6.5 months in the cytoreductive arm and 11 months when HIPEC was added. But at least a signal here that HIPEC works, and this was significant, so a positive study. In addition, shortly after this, we heard from the French group with the cytochip study. So this was presented at the GI ASCO in, I believe, 2018, and subsequently published in the Journal of Clinical Oncology. And again, very similar to the Chinese study is that they compared patients that underwent cytoreductive surgery, gastrectomy, and HIPEC compared to cytoreductive surgery and gastrectomy alone. I think what's most impressive about this is that the 20% 5-year survival rate. Now, it is a selective study, but still, that's a very good long-term survival rate for established peritoneal disease. But again, the peritoneum is still a problem, as shown here in the green and the red. These were patients that had at least some component of a peritoneal recurrence, whereas the patients in blue had an isolated extraperitoneal recurrence. So even with this aggressive therapy, the peritoneal disease was a problem. And of course, this is selective. It was over many years in patients that had good response to therapy. And it was a retrospective registry study, but still very, very impressive and another signal that HIPEC may work in gastric cancer. So with that in mind, with those studies, we wanted to also be selective in our trials. We wanted to be safe, and there was no completed trials of HIPEC in gastric cancer prior to this study. And we wanted to choose patients with low volumes disease and really minimize complications. So we thought we would leverage minimally invasive surgery and a neoadjuvant approach as a way to do this. So the purpose of this study was to prospectively evaluate HIPEC in a neoadjuvant fascia via a minimally invasive approach, and then patients with resolution of their extragastric disease after multimodality treatment would be offered gastrectomy. So this was a selective approach. We were very worried at this point about combining gastrectomy and HIPEC together. It's subsequently been shown that the risks do not go up much by adding HIPEC, but we didn't know this at the time, and so we wanted to separate the HIPEC from the gastrectomy. So we're going to make the HIPEC work before we put patients through a gastrectomy alone. This was a phase 2 single-arm study over approximately a 2-year period, and it was patients with established stage 4 disease. But like I mentioned, we wanted relatively low volume peritoneal disease. So we did that by only including patients where the peritoneal disease was not clearly identified on imaging. We didn't set a distinct peritoneal carcinomatosis index, but we just established that it could not be visible on radiologic imaging. And that set the bar pretty high for having a pretty low peritoneal disease stage. Or it could be patients with positive cytology only. That was felt to be a great candidate for this trial. And these were 2 patients that were included in the trial. So this was the inclusion criteria, either positive cytology, and this was a patient with a cardia tumor with serosal invasion, as shown here in the blue, and the washings were positive, and this was a patient with carcinomatosis that did not show up on imaging and was also included. And both of these patients did subsequently clear their peritoneal disease and went on to gastrectomy. So this is the trial design. So all patients were treated with systemic chemotherapy. We felt this was important, as systemic chemo is a standard of care. And then patients underwent a laparoscopic HIPEC approach. We did use flat doses of the mitomycin and cisplatin. We could repeat this up to 5 times. Chemoradiotherapy was allowed, and although I think we could be criticized for utilizing a local or regional treatment like radiation, we wanted to set the bar very high before we put patients through a gastrectomy alone. But if patients got to negative cytology and no carcinomatosis and then no CT imaging evidence of metastases, we offered gastrectomy alone. The inflow and outflow rates were 42 degrees going in and approximately 39 degrees going out. We'd usually have about 1 liter per minute of the perfusion. We performed the perfusion for 1 hour. We did increase the cisplatin dose compared to what the Chinese trial used, and we added thiosulfate for kidney protection. And this is a picture of our inflow and outflow cannulas here. This is our flow diagram. 19 patients were enrolled, and ultimately we got to 7 patients that had negative cytology and no carcinomatosis. 5 elected to undergo resection. These are our 19 patients. They're relatively young. Median age was 51. Most patients had poorly differentiated tumors. Most patients had signet ring cells present. Most were present in the stomach, although there were a few GE junction tumors. Most patients did have carcinomatosis, while 6 patients had positive cytology only. The median cycles of chemotherapy was 8. Almost 3/4 of the patients did undergo radiation therapy. Again, we just wanted to set that bar very high before we put them through a gastrectomy and ensure we could get negative margins. About half the patients underwent 1 laparoscopic HIPEC, while the rest of the patients underwent multiple laparoscopic HIPEC procedures. 2 patients underwent 5 laparoscopic HIPEC procedures. Thankfully, the morbidity was very low. So in 38 procedures and 19 patients, we only had an 11% morbidity rate. Really, the worst complication we had was a pneumothorax that required a chest tube. This was when we were too aggressive about removing some peritoneal disease at the time of laparoscopic HIPEC. Thankfully, there was 0 90-day mortality. Median hospital length of stay was 3 days. At a median follow-up of 19 months, our 3-year overall survival rate was 44%, which is promising compared to historical reports. But again, I have to acknowledge the selection bias here, and that these were all patients that had a good response to systemic therapy and then were allowed enrollment on the trial. So again, that's the nature of a single-arm phase 2 trial where we were very selective. But median overall survival was 30 months, which is very good. I would like to show a video that just outlines some of the lessons we learned during this trial.
We have recently completed a phase 2 clinical trial of laparoscopic HIPEC, or hyperthermic intraperitoneal perfusion with chemotherapy, for patients with metastatic gastric cancer. Intraperitoneal chemotherapy is unproven in the treatment of gastric cancer. Here's our trial scheme, which demonstrates treatment with a systemic chemo, followed by laparoscopic HIPEC. If all peritoneal disease resolves, then we can offer gastrectomy. So the purpose of this talk was to demonstrate our technique of laparoscopic HIPEC and review the lessons learned. Patients included in this trial had carcinomatosis or positive cytology. This is a diagnostic laparoscopy at the time of the first laparoscopic HIPEC. The patient had had previous biopsies and was demonstrated to have positive cytology. We can see multiple previous biopsies. There is a port site. The left liver is retracted anteriorly, and the stomach is thickened, stiff, consistent with serosal tumor invasion along its length, or Leonidas plastica. We perform cytology at the beginning of each procedure by instilling a liter of normal saline with 500 milliliters on each side of the diaphragm. We then agitate the abdomen briefly to bring the fluid into contact with the peritoneal surfaces. The fluid is then aspirated from the right upper quadrant as well as the left upper quadrant, and we try to obtain a minimum of 750 milliliters, and our cytologist will perform cytologic analysis of the entire specimen. We then perform biopsies of all the previous biopsy sites. We are essentially stripping the peritoneal surface, as it is impossible to identify scar from persistent peritoneal disease. This can also be performed easily with a harmonic scalpel. Although higher on the thin aspects of the diaphragm, it is easy to create a pneumothorax. Once the biopsies are complete, we bring in our outflow cannula through the right upper quadrant 12mm port and place the cannula into the right upper quadrant. We attempt to place the cannula high into the right upper quadrant to allow the falciform ligament to prevent a quick left to right flow of the heated perfusate. Here is our inflow cannula, which is a cardiac venous catheter placed into the left upper quadrant anterior to the stomach. This demonstrates our perfusion setup and the agitation of the abdomen that we perform for 1 hour. Perfusion rates are maintained at approximately 1 liter per minute. The perfusion is complete, and despite our best efforts at removing the fluid through the outflow cannula, we still have significant residual fluid. The outflow cannula is removed under direct vision, as it is not uncommon to have omentum or pericolonic fat adherent to this cannula. The inflow cannula is now easily removed. This shows some of the suction marks from the outflow cannula on the liver, highlighting the importance of placing the cannula away from the bowel and the need to promptly investigate any issues with the outflow cannula. We then remove all remaining perfusate from the abdomen, confirm hemostasis of all biopsy sites, and then our port sites are closed. For the next 2 patients, we will demonstrate the effects of performing multiple laparoscopic HIPEC procedures, which has not been described. Here we see scattered 1 to 2 millimeter white left upper quadrant and diaphragm deposits, biopsy confirmed as carcinomatosis from gastric cancer. And here we show the same pattern of carcinomatosis in the right upper quadrant. This video demonstrates the biopsy sites in the left upper quadrant that we showed on the previous slide, as demonstrated here. This also demonstrates resolution of most of the peritoneal carcinomatosis. Proponents of intraperitoneal chemotherapy often make the statement that systemic chemo is not effective against peritoneal carcinomatosis, but my experience is that systemic chemo can have a significant effect, as shown here. There are some residual lesions that are either scar or persistent disease. The stomach remains thickened and stiff. Similar to the left upper quadrant, the right upper quadrant also shows an excellent response. The patient has previously undergone extensive biopsies and a HIPEC procedure. Now the peritoneum has more diffuse white changes, and the liver is adherent to the left upper quadrant diaphragm. This patient also developed ascites after these procedures, which was negative for malignancy on multiple evaluations. Now we have a patient with a gastroesophageal junction tumor treated with 5 HIPEC procedures. The patient required a previous laparoscopic J-tube at diagnosis, which we demonstrate here, and this is often a site of peritoneal disease. The peritoneal surfaces are relatively clear, and the gastroesophageal junction and cardia demonstrate serosal invasion. We do not have a video of the second procedure, but this is the third HIPEC procedure performed approximately a month after the second laparoscopic HIPEC. You can start to see diffuse white changes to the peritoneum. There are multiple non-healing biopsy sites from the recent previous HIPEC, and there are now multiple areas that require biopsy to confirm lack of peritoneal disease. Now, after the fourth HIPEC, the stomach looks very similar, but perhaps more thickened white area in the cardia, which could be persistent disease or a reaction to the inflow cannula, which is placed directly over this area. The left upper quadrant trocar site, just cephalad to the J-tube, demonstrates the effects of repeated access, as demonstrated here. The biopsy sites demonstrate a thickened appearance that require repeat biopsies. There is trace ascites, and the liver is adherent to the diaphragm. During the fifth laparoscopic HIPEC procedure, we see that the stomach is showing some slight progression, and this was confirmed endoscopically. The white peritoneal changes don't seem to change considerably. 5 laparoscopic HIPECs is the maximum we have performed in an individual patient, and we have had to essentially remove all of the previous biopsy sites. Now I'd like to demonstrate some lessons learned regarding the outflow cannula. In this patient with a large amount of redundant and loose omentum, we realized the importance of placing the cannula high over the liver during the perfusion. Now, despite our efforts, here we illustrate the difficulty in removing the omentum once it has entered the outflow cannula. The holes are only 2 millimeters in size. We were ultimately able to remove the omentum without placing an additional port, but this could be more of an issue if pericolonic fat or perigastric fat were involved.
Okay, so with that in mind, what we found is that there were many patients that tended to just stall after repeated laparoscopic HIPECs. And we felt that we had to be more aggressive about then being able to combine gastrectomy and HIPEC at the same time. Also around this time, there were many studies, such as the CytoChip study, which showed a relatively low rate of complications with the addition of HIPEC to gastrectomy. So with that in mind, this was our next generation trial after the laparoscopic HIPEC trial. And so in this, again, very similar inclusion criteria, although the peritoneal disease could be visible on imaging. All patients then underwent systemic chemotherapy and then at least one laparoscopic preoperative HIPEC. Now, I can't argue that we know that laparoscopic HIPEC works. We have not performed a randomized controlled trial. But we do need a diagnostic laparoscopy at any rate, so it made sense to add a laparoscopic HIPEC as part of our inclusion criteria for this trial. And then if patients had disease that we felt was amenable to a complete cytoreduction, then patients were enrolled in the trial and offered cytoreduction, gastrectomy, and HIPEC. There was no planned adjuvant therapy. And this is our median, at a median follow-up of 3 years, this is our survival. So we had 20 patients on this trial, and our 3-year overall survival rate was 30%. Median overall survival was almost 2 years. But what we felt was most impressive is we had several long-term survivors, and now we still have 3 patients that currently have no evidence of disease, and they're coming close to 5 years. So 3 out of 20, we felt that that was an improvement. Now, during this time, we also performed a phase 1 trial to identify the optimal dosing regimen. And this was also during the time of the FLOT study, and there was a lot of enthusiasm for triplet chemotherapy and also working in a Taxol. And there's a lot of reasons why a Taxol might be a good drug to use during HIPEC. But again, we were stuck with these flat doses of mitomycin and cisplatin based on the Chinese trial and also our previous trials. But then we added paclitaxel, and we got up to 60 milligrams per meter squared without any dose-limiting toxicity. Also during this time, a little after that, there was the Periscope 1 Dutch trial that was published in the British Journal of Surgery. And so it's just nice to see that they found similar results as far as the dosing of their Taxol. So it's always nice to see similar findings across different trials. But what are we supposed to do in the current clinical setting, especially without clear guidelines that state that HIPEC should be used? Well, I'll tell you how we've gone about it. And the first thing is that all patients should be treated with systemic chemotherapy. That's the standard of care, and you do want to be selective in choosing patients going down this peritoneal treatment approach. And then we also feel that a multidisciplinary conference is key in getting all of the modalities into the conference to identify the best treatment option. But in select patients, we do offer a laparoscopic HIPEC. Now, again, that's nice because you get a diagnostic laparoscopy, you get to restage the peritoneum. We know that CT imaging and standard imaging is very poor at identifying and staging peritoneal disease, and it makes sense to add a HIPEC as part of that. Or you can consider second-line chemotherapy. I'll talk about this a little bit, but there is some data out there that laparoscopic HIPEC may be good for intractable ascites and a good treatment option. But regardless, after the laparoscopic HIPEC, we're back to the multidisciplinary conference, and then we just decide, is it the right thing to do to go down a gastrectomy, a cytoreductive surgery, and a HIPEC approach? Or do we want to go down a selective neoadjuvant repeated laparoscopic approach before we consider gastrectomy? Of course, we always have next-line chemotherapy, phase 1 trials, and there are also just ongoing studies that are demonstrating the benefit of immunotherapy and other targeted therapies. And so those obviously have to be brought into the discussion, and your medical oncologists are very helpful there. But with these challenges in mind, in 2018, there was a Chicago consensus panel with multiple experts came together, and they did include a chapter on how to treat synchronous peritoneal gastric metastases. And so they listed out the options as part of that consensus guidelines. This was published in the Annals of Surgical Oncology as well as Cancer. And it includes cytoreductive surgery and HIPEC, also a neoadjuvant intraperitoneal and systemic approach, or the NIPS approach. Laparoscopic HIPEC are certainly trial options. So it's just nice to have a summary document to summarize a lot of the treatment options available. I wanted to mention that laparoscopic HIPEC has been reported in other disease sites. And so this was a systematic review, and it included gastric, breast, mesothelioma, ovarian, colorectal, pancreas cancers, and appendiceal cancers. 183 patients over 8 studies, published in the Annals of Surgical Oncology. I know it's getting a little old in that it was published in 2012, but it's just a really great summary. Now, I should mention that the neoadjuvant approach was very small. It was only present in 5 patients. But adjuvant was the most common. But this was interesting, was that the 76 patients that underwent palliative laparoscopic HIPEC. Now, thankfully, the minor complications across all these patients was very low. There was only 13 complications and no deaths. Of course, there is a selection bias here, and these were all retrospective reviews. But strikingly, it was 95% effective in refractory malignant ascites. Now, I will mention that I've used this in my own patients with refractory ascites after multiple paracentesis procedures, and I have not found it to be 95% effective. But I think it is a treatment option and something worth studying, so I hope to see more data on the use of it as palliation for malignant ascites. It's just such a difficult problem to deal with. But I think when talking about a neoadjuvant HIPEC approach, it helps to take a step back and talk about how we've used neoadjuvant therapy for localized tumors. And so there's many theoretical advantages. One is preoperative downstaging and improving resectability. There's also reduction of local regional failure and the ability to obtain negative margins. You can also assess the therapy response in the tumor, and then only effective therapy is continued after that the response has been identified. You can avoid unnecessary resections by allowing time to assess tumor biology and being more selective. Perhaps it prevents seeding secondary to intraoperative manipulation after a response. But it is clear that patients tolerate therapy better before surgery than afterwards. And so with that in mind, perhaps we can offer a neoadjuvant therapy approach for metastatic tumors. And I think there are many options for that. And although I was focusing on laparoscopic HIPEC today, I did want to acknowledge all the other work that's been done. So there certainly is an intraperitoneal paclitaxel approach. And we've seen the Phoenix study out of Japan. Although that was a negative study, I think some of the subset analysis suggests that there might be a benefit. And so we're certainly watching those ongoing studies go on in Japan and China. There's also the PIPEC approach, or pressurized intraperitoneal aerosol chemotherapy. There's the NIPS approach. I think this was popularized by Dr. Yanamura out of Japan with a neoadjuvant intraperitoneal and also a systemic chemotherapy approach. And then I've just been really feeling enthusiastic about a lot of the data on conversion gastrectomy that's been coming out, particularly out of Asia. And so I think we all want to get to the point to where we can perform a gastrectomy, and we're all looking for some way to be more selective and to identify a response to therapy before we put patients through a gastrectomy where we start to limit their quality of life. Using the intraperitoneal paclitaxel approach, just as an example, I did have the opportunity to meet with a lot of the investigators from Japan and Dr. Ishigami, the primary investigator, to learn about the Phoenix trial. And again, I was just very inspired by their approach and their rationale for gastrectomy, where they try and control the peritoneal metastases with intraperitoneal chemotherapy. They look for disappearance of cancer cells on cytology. They perform a liberal use of laparoscopy to look for the disappearance of peritoneal metastases and shrinkage. And then they consider gastrectomy. And so they are pushing the envelope in this approach. And so I just use this as an example that can be applied to other modalities. We do have a single-arm phase 1 study where we're looking at the intraperitoneal paclitaxel approach. Now, systemic chemotherapy, as I mentioned, is the standard of care. And we had to work this treatment modality into our established treatment regimens. And so our medical oncologist did not agree to performing intraperitoneal paclitaxel placement up front. But so we have to treat with systemic chemotherapy first and then look for those patients that have had a response. Then we consider diagnostic laparoscopy and intraperitoneal port placement. We stage the peritoneum. And then we're performing an intraperitoneal paclitaxel approach of weekly treatment, 3 weeks on, 1 week off for 2 months. And then we perform a repeat laparoscopy. And in this way, we'll be able to identify that the paclitaxel works before we consider putting a patient through a conversion gastrectomy. It does go up to 100 milligram per meter squared. We are on the highest dose level now, and so we hope to have some findings to be able to report soon. So in summary, I think hopefully I've shown that the peritoneum is the best target to improve survival in many cancers, and particularly in gastric cancer. Laparoscopic HIPEC, I believe, can play a role, importantly through clinical trials and multi-institutional studies. And so I have proposed this on our cooperative group setting, but it's very difficult to accrue patients to trials with a non-surgical arm, and that most patients do want to be aggressive and have that surgical arm with the laparoscopic HIPEC. So we are looking for a good comparative arm to include in a randomized control trial, but those discussions are ongoing with our cooperative groups in our nation. Laparoscopic HIPEC, though, is safe and feasible. I think there have been multiple studies that have shown it is a safe procedure with a very low 90-day morbidity and a close to 0 mortality rate and a relatively short stay in the hospital. We do have data on phase 1 and 2 dosing regimens, and although I don't propose that it's a clear standard of care, as we have no randomized controlled trials, I think it is acceptable to consider laparoscopic HIPEC and then gastrectomy and HIPEC off protocol in select patients that have had an excellent response to therapy. But really, perhaps the most important thing is we do want good correlative studies here. This offers an excellent opportunity to obtain tissue and to collaborate with our basic scientists. And so I've just included a few studies that we've published using profiling of peritoneal metastases and looking at heterogeneity of peritoneal disease. So I think if we're going to identify new targets and really make inroads here, we have to collaborate with our basic scientists. All right, I'd like to thank you very much. It's always been a dream of mine to get to visit Singapore, and so I'm certainly very sorry that I haven't been able to do that this time, but look to visiting in the future. And of course, I want to invite everybody to the International Gastric Cancer Congress in Houston. We had initially planned for this in 2021, but you know how much we like to draw red lines through things here at MD Anderson, and so we had to draw a red line through 2021, and hopefully we'll make it in 2022. It's planned for March 6th to 9th, and again, hope to see everybody there. So just thank you for the opportunity and the high honor of being able to present to you today.
Thank you, Professor Badgwell. I think a lot of very interesting trials, and we await the results of some of your work that's coming out of there. Maybe I'll just get the ball rolling with one question first. For your patients that you recruit on trial or off trial for the CRS and HIPEC for the gastric cancers, what are your inclusion criteria and what PCI cutoff do you use for these patients?
Yeah, in a lot of my trials, I did not establish a clear PCI or peritoneal carcinomatosis index. I think most studies out there looking at this use a PCI of 7 or less. I mean, it is clear that the higher the PCI, the worse patients do. I can tell you in our trials, our median PCI was 3, so it was very low. But I think the most important thing really is the response to systemic therapy. In that if a patient is not responding to systemic therapy, it's very unlikely they're going to respond to cytoreduction and HIPEC. So I kind of consider, at least at this point, HIPEC and gastrectomy and HIPEC as adjuvant surgery, meaning you have to have an excellent response to chemotherapy, and it's best seen as kind of a cleanup procedure, especially in microscopic disease.
Yeah, so for a lot of these patients who do have a good response, when you go in again and you don't see any macroscopic disease and the cytology is negative and your biopsies are negative, which occurs quite commonly for us here actually, do you then just do a conversion gastrectomy and then give the HIPEC, or do you include some peritonectomy procedures?
Well, I do include some peritonectomy procedures, but it's usually only because those patients have had previous biopsies or their scar, and of course I can't tell the difference, and I'm pretty liberal about that. I also like to perform many biopsies because I think you just perfuse the peritoneum better that way, and of course those sites were usually where you've established disease. But yeah, I've been very interested in conversion gastrectomy because I've seen some people just perform the gastrectomy alone, but when we've tried that here in the United States, and we try it every now and then, we tried it for many years, even for patients with positive cytology that converted to negative, we just did a gastrectomy alone, they always recurred. It was clearly stage 4 disease. And so I think it's important, at least in our population, if we're going to do a conversion gastrectomy, something has to be added to it, some kind of a peritoneal treatment.
Okay. Do we have any other? I think Professor So has a question. Oh, Jim.
Thanks, Professor Badgwell, for the very nice talk as well. Just wanted to ask you about patients who have both peritoneal mets as well as metastases in the rest of the body, like in the liver or in the lung. What's your approach to those patients with metastases, both systemic as well as peritoneum?
Yeah, we have excluded those patients from all of our trials if they have sites of metastases outside of the peritoneum. We had a few patients that had perhaps distant lymphadenopathy that resolved with chemotherapy. And so I think, that's one we probably are a little bit more aggressive with. Those were the patients that did seem to do the best in, for instance, a FLOT3 study where they, looked at performing surgery in metastatic disease, or some of our own studies, pre-HIPEC where we did surgery for metastatic disease. But yeah, certainly for something like the liver, the lung, or somewhere else, I don't think it would go with a peritoneal approach for that.
Do you think there may be a role in bidirectional therapy, combining systemic chemotherapy with peritoneal treatment as well?
Right. I think that's an excellent approach. That's not something we've embraced primarily because of the practice patterns of our medical oncologists. They are reluctant to administer intraperitoneal and systemic chemotherapy. So I have looked to others for that, but I think that's a fantastic approach, really, because the peritoneum is difficult to administer chemotherapy to, and it just makes a lot of sense. I've been impressed with the Phoenix data, some of the subset analysis, and so no, I think it's a great idea, and I wish I could do it sometimes, but just haven't been able to do it yet.
Professor So?
Yeah, thanks. Hi, Brian. Good to see you online. Yeah, I have a question and a comment. And my first question is, you know that all along our effort is on IP paclitaxel, followed by a conversion gastrectomy, or a pipette in the last few years. And I wondered that I was quite curious that when you finish a laparoscopic HIPEC, why you need to remove the residual fluid, residual chemotherapy? Because when we give the IP paclitaxel or during the pipette, actually we leave the chemotherapy inside the abdominal cavity. And we thought that this is actually has some oncological effect, so that the patient will have continued cytotoxic chemotherapy even after the session, after the surgery. What's your take of it? Why you need to remove the chemotherapy solution at the end of the HIPEC? Can we leave it there?
Yeah, that's a fantastic question. I think you're exactly right. But, I should note that first laparoscopic HIPEC trial was the first completed trial of HIPEC in the United States. So I was just, I was scared, frankly. And so I just had, having adverse events was not acceptable, and I had to be very cautious with that trial. But yes, as we've moved forward, we have not removed all the chemotherapy. Now, I will say we were using pretty high doses. We were using good doses of mitomycin, cisplatin, and paclitaxel. And so I do worry if we had left all that chemotherapy in there, we might have seen some adverse events with that. But, paclitaxel just has it's such a big molecule, and it stays around, and there's very little systemic toxicity. I think that makes a lot of sense to leave that in. So yeah, we have gotten more aggressive with leaving chemotherapy in there.
Yeah, my second question is about your comments on conversion surgery. And we do the surgery, our practice is very similar to Ishigami. Therefore, that after the conversion surgery, the patient will immediately put back on the intraperitoneal chemotherapy, or together plus or minus systemic chemotherapy, because we believe that this is a stage 4 disease. The patient needs to continue systemic treatment, either regionally or systemically. Therefore, that's why our focus is just remove the primary organs, so that to minimize the risk of the complication associated with the peritoneectomy. And also just to remove the primary cancer, to reduce the chance of developing resistant clones from the primary cancer. Therefore, it's really a combination approach. The surgeon play a part to remove the primary tumor after the chemotherapy response, and then continue systemic therapy with our medical oncologist colleagues. So this is our rationale of just performing a conversion gastrectomy without touching the peritoneum.
Yeah, I think that's great. And I've noticed that Dr. Ishigami often mentions the importance of continuing intraperitoneal chemotherapy postoperatively. I've wondered at times if perhaps adhesions could keep the catheter, or the diffusing of the chemotherapy from reaching all of the abdomen, or perhaps trapping tumor cells in adhesions. But it does seem to work. And so, yeah, I have been watching that data, and I think it's great data. And it's been inspiring to see that as a potential treatment approach. Yeah.
Thanks. Yes, I think I've asked Professor Ishigami and Professor Yonemura before, and it doesn't seem to be a problem with adhesions after the conversion gastrectomy. But if you do give the HIPEC after the gastrectomy, then they have encountered quite a couple of cases of adhesions, and then it becomes a little bit more difficult to leave the catheter inside and continue the chemotherapy after. I think just one last question for me. I think you mentioned, about your dosages for the intraperitoneal chemo, and that you're using the standard dosages, and that was from the study from China. Would you be looking to move towards using body surface area dosages? The profile of your patients might be quite different from that of the Chinese patients.
Right. And we've moved forward with it in the paclitaxel, and I think we do have to move forward with it in the mitomycin and the cisplatin. With that being the only evidence that was out there, I really was, stuck using that. But I think now that we've become more familiar with it, there's ongoing trials coming out. The GastroPEC trial which used BSA adjusted doses of mitomycin cisplatin, is going to be being presented at ESMO in a very short period of time. So look to that to come out. And although it did not complete accrual, there should be some great data there. So I think, as more studies have come out, we've gotten more used to that.
Okay, great. I think that's all the questions we have for you. Thank you once again for your talk, and we hope to welcome you to Singapore again sometime in the near future. Thank you.
Thank you.